session in which we are going to focus predominantly in terms of technological advances with regards to pediatric endocrinology. And we know pediatric endocrinology is one branch which has witnessed a lot of changes. And often when we talk about technology, we traditionally have been talking about how new devices have come up, or whether you've got a new way of giving glucose monitoring, or you're doing some new insulin. But what we're talking about technology today is to how these protocols are properly implemented at the last point. And this is what the aim is, to develop point of care tools which can help out in terms of improving technology. So our aim has been to develop tools which can be implemented in different regions, across resource settings, across the different exposure in that regard. And we'll be focusing about how these point of care tools can help guide 5 key disorders in the form of growth, puberty, thyroid, glucose, and electrolyte disorders, and how we can individually look at in terms of evaluation, assessment, and management of these disorders. iPedendo basically is a way in which we want to go out in terms of developing tools which will help in terms of evaluation of these key disorders using a very novel approach of mobile application, which has been there now for some time, but we have been keep on editing them in terms of improvement. So our work with regards to pediatric endocrinology actually started maybe around 13-14 years ago, when we started with workshops on different disorders. This was much early. Then we gradually developed those workshops into 6 modules, which were in the form of a practical pediatric endocrine course, which we conducted across the country. Then we realized it's going to be difficult to keep on conducting programs in that extent. So we went on to social media in terms of YouTube, in which large number of videos were available. We started an on-site fellowship around 6 years ago, and till date we have got 11 fellows who have joined who have done or are doing the clinical fellowship in that regards. Then we realized that we also need to spread out the message, and that led to the development of MedEClasses around 5 years ago, which is a portal dedicated towards improvement in pediatric endocrinology, which then further led to the publication of multiple books, and then the mobile application. And we are going forward in terms of these regards, and we'll talk about the subsequent developments which are happening in that regards. One of our important interventions is the e-learning tool, which is in the form of a YouTube channel, which has got extensive resources. Pretty much everything about pediatric endocrinology is there, and it's quite widely viewed across the globe as well. We have got our website, learning.growsociety.in, which provides validated courses with regards to various aspects of pediatric endocrinology, and they range from small courses like growth, puberty, to more specific and larger courses in the form of the fellowship programs, as well as the pediatric endocrinology for postgraduates and other programs in the form of, which are available on an online or an online on-site hybrid model. We have got 3 key books which focus from practical approach to basic to advanced pediatric endocrinology, which provide a comprehensive understanding of these tools. But what we realize essentially is that with all the knowledge and resource, ultimately, when you are seeing the patient for the first time, you may get puzzled in terms of how to implement all the knowledge, and therein the confidence becomes a bit difficult. And whatever you remember will not always be a sort of a standard of care, and often that results in errors. So there is a need in which we really combine between the knowledge which is there in terms of available, in terms of resources, in terms of guidelines, in terms of algorithms, with what we really practice in that regard. So how do we do that? There are multiple factors required. You need to decide about which tests to order. You need to look at the interpretation of each and every clinical sign, as well as the investigations. You have to then decide about what treatment is there, and that's why you need to have a very comprehensive approach on that. So we tried to develop a solution which can help out in all of these things in terms of analyzing the symptoms, interpreting the key parameters, advising investigations, then comprehensively looking out on investigations and deciding about that treatment. And we realized that the most powerful device there would be a mobile application, because if you think of it, mobile app is available to everybody, and all of us keep carrying that mobile everywhere. If you talk about, let's say, a web portal based approach, it requires at least an office setting. So this can be used across settings, very easy to do, and you just develop and can be used across the globe as well, providing same standard of care at different regions in that perspective. So this led to the development of our mobile application, which was developed a few years ago, which is in fact the most downloaded endocrinology app all across the globe, with number of installs and a lot of publication that we have done in that regards. The way we structured this is to develop pathways which provide us guideline-based approach in an algorithmic manner. You have to question and answer, and you will get the final diagnosis in that regards. There are approach pathways and management pathways. So they will guide stepwise management and approach. Suppose you want to know about hyperkalemia, it will ask about specific conditions, and then we'll go in terms of diagnosis. More recently, we move more towards interpreters, which are instantaneous, because now the general tendency, you don't want to go and wait for a long time. So you just put in some data, like in the form of a thyroid interpreter, you interpret the thyroid results and you get the results automatically. Similarly, the bone age interpreter, which has been published and validated, which provides a wide, and we'll discuss about this tool as well as more disease-oriented interpreters, in which based upon your symptoms, we will then decide about what workup is required and how do you reach a particular diagnosis. So we've got multiple interpreters like puberty interpreter, obesity interpreter, DSD interpreter, which really guides, and we are working on a combined electrolyte, calcium, and glucose interpreter, which is going to help out in that perspective. Now, once you order a test, you need to really understand the intricacies of when to do, how to interpret, and age-related. So, of course, we don't have all the information, and that's why we have put it every detail in the diagnostic section and information about every drug in the therapeutic section. So within the app, you can actually, once the patient comes to you, decide about what investigations you want to do. You can then decide about how to send and all the information is there. Once the results get in, you can interpret those results, then you can prescribe and you can know about the particular drugs as well. So we sincerely hope that this endocrinology application is the bridge between the evidence base and the practice. So this is expected to result in evidence-based practice, and we already have publications which have shown its improvement in care in terms of decay, growth, and bone age assessment. And we are working in terms of validation for many more disorders like diabetes, DSD, puberty, obesity, thyroid, and so hypoglycemia basically means that your blood sugar levels are low. There are only two reasons: either you are not producing enough glucose or you are utilizing more. So if you have a problem in production, if you give the physiological replacement dose of 6 milligram per kg per minute, this will take care of it. If it's increased utilization, you may need a much higher infusion rate of approximately 12 milligram per kg per day. These substrate defects may be because of prematurity or SGA, or metabolic effects because of endocrine causes, in which case you will have micropenis or midline defects which will be there. Then you may have a metabolic defects like galactosemia, in which you will have hepatomegaly onset around 3 weeks with hypoketotic pattern, and cataract will also be a clue. Increased utilization could be because of sepsis or cardiac failure, which will be very evident to you, or most commonly because of hyperinsulinism, which is the most common form of persistent hypoglycemia, which is typically non-ketotic. It may be because of maternal diabetes or beta blockers, lasts around 1 week. It may be prolonged 6 to 8 weeks because of a hypoxia or a SGA response. And this prolonged hyperinsulinism is the most common cause of hyperinsulinism which you will encounter. They will have a low birth weight rather than macrosomia, and they will improve over 6 to 8 weeks with diazoxide. And finally, you may have genetic causes with severe macrosomia requiring lifelong therapy. So once you have hypoglycemia, the body will respond with every way to correct it. So what it will do is that it will inhibit insulin. So you should have zero insulin when you have hypoglycemia. You should have a ketone response. Everybody with hypoglycemia should produce ketone unless there is hyperinsulinism, fatty acid oxidation defect, or problem in the galactosemia or fructose intolerance. So ketone should be more than 2. Your growth hormone and cortisol levels should also be sky high. So don't compare a normal range. A normal growth hormone and a normal cortisol during hypoglycemia is inappropriately normal. It's low. This means there is deficiency. And of course, lactate should also be low in that perspective. So if you really look at these parameters and what we call as critical sample, you will get the right answer in that regard. So any detectable insulin in this hypoglycemic phase is hyperinsulinism. Non-ketotic, you have to suggest of specific causes. I discussed hyperinsulinism being number 1. If your lactate is high, you're dealing with galactosemia and gluconeogenic defect. And if your growth hormone and cortisol are normal or low, it is multiple pituitary hormone deficiency. So the key parameter, of course, is ketone. If your ketone is low, only hyperinsulinism, fatty acid oxidation, maybe add galactosemia there. Lactate high, you are dealing with GSD1 or fructose 1,6-bisphosphatase deficiency. pH acidosis, again, you add organic acidemia there, and insulin, if it is detectable, is hyperinsulinism, and then glucagon response is required in certain scenarios. So the approach is, if you have hypo or non-ketotic hypoglycemia, reducing substance being positive, it is galactosemia. Negative, look at insulin. High or detectable levels suggest hyperinsulinism, otherwise it's a fatty acid oxidation defect. If your ketone is high and lactate is also high, you have got a GSD1 or gluconeogenic defect. If your lactate is normal and there is a large organomegaly, this is the rarer GSD variant, GSD 3, 6, and 9. If they are not there, look at cortisol and GH. If they are low, it's pituitary defect. If they are normal, it's accelerated starvation. So basically, we're looking at ketone, we're looking at lactate, insulin, urine-reducing substance, you will get the diagnosis. So when you talk about critical samples, take the samples, but don't process all immediately. Process as and when required in that regard. So now, Alapan, you can come back. 3-week-old boy with seizures, sugar is 28, ketone is 2.3, sodium is 128, potassium is lowish, lactate is normal. What are you thinking about in this regard?
So in the setting of a hypoglycemia, there is production of the ketone. So this is ketotic hypoglycemia. So I would like to see.
And there is something else?
Lactate is low.
And
low sodium.
Hyponatremia. So if you forget about algorithm, hyponatremia, hypoglycemia, what are you thinking about?
And this is something like a cortisol deficiency or...
So a multiple pituitary hormone deficiency, because a single hormone deficiency is usually not sufficient to cause hypoglycemia. So now we've got specific approach pathways which talk about when do you want to evaluate. So they go step by step, and it's basically saying your GIR is low, and as you said, your ketone is more than 2. In this regard, your cortisol level becomes important. So what we are finding, he also has micropenis. So this is multiple pituitary hormone deficiency. Now, in this regard, the second case is again a 3-week-old boy with failure to thrive, hypoglycemia with a low GIR with hepatomegaly. Now, what are the causes of hepatomegaly with hypoglycemia in the newborn period?
So in the newborn period, if a child presents with hypoglycemia, hepatomegaly, there could be chance of hyperinsulinism possibility. There would be galactosemia if it is present or not. It could be
GSD1?
No.
It does not
present hypoglycemia in the neonatal.
Beckwith-Wiedemann syndrome is another possibility. So yes, now you will like to look at what?
I would like to look whether it is ketotic or non-ketotic.
So it becomes important. So it's persistent. So you will evaluate for hypoglycemia only if it's persisting beyond 48 hours or your glucose requirement is more than 12. So in this regard, ketone is negative. So low glucose requirement, non-ketotic. Is it hyperinsulinism or is it more likely to be galactosemia?
It's more like to be galactosemia because the infusion rate, the requirement is less.
So reducing substance was positive, so this was galactosemia. 10-day-old girl with hypoglycemia, GIR is 14. Now, of course, you start thinking whether you need to evaluate or not. So more than 2 days, anybody who is above 2 days of life has no business to have hypoglycemia. All these transitory things happen in the first 48 hours. So you didn't require evaluation. Ketone is negative. So what are you looking at here?
Is non-ketotic hypoglycemia
with high
GIR rate.
So it's very, very characteristic.
Of hyperinsulinemia.
Reducing substance is negative. Insulin is 3, which is reported as normal.
But this is detectable in case of hypoglycemia. So this is
clearly hyperinsulinism. 6-month-old boy with lethargy with blood sugar of 36, ketone positive. So now we talk about older individual, ketotic, and he has got lethargy and high lactate. So differentials?
Differentials are 3. It could be a GSD type 1, gluconeogenic defect, or organic acidemia can present sometimes.
A bit unlikely, but yes, they may. Hepatomegaly is huge. Now your differentials become less. GSD1 versus a gluconeogenic defect. And here, of course, if you look at this, this is a non-ketotic response and your lactate level is high. Now your differential is very less. You're basically looking at a GSD in this scenario. 1-year-old girl not waking in the morning, blood sugar is 24, doesn't have a hepatomegaly, and the ketone is strongly positive. Lactate is normal. So what are you wanting to do now?
This is ketotic hypoglycemia with no organomegaly, and there is less lactate is negative. So I'll want to see the GH and cortisol level in that scenario.
So this is, you're thinking go more towards the accelerated starvation, but you have to first exclude GH and cortisol. So growth hormone and cortisol are very, very high. So this makes them unlikely. You have to think of more of a accelerated starvation. This is available in the form of our app, which has got so many approach pathways, management pathways, which help you guide specific management, and you can download it through both Android and iOS stores. We also have the various courses for different groups, from the postgraduates to the fellows to the pediatricians, and we have got specific courses for the pediatricians as well as postgraduates in that regards. And of course, this mobile application will help you reach a diagnosis.